بسم الله الرحمن الرحيم. النهارده هنبتدي بارت 3 من الفور بارت سيريز اوف دايابيتس ميليتس. بارت 1 وبارت 2 احنا اتكلمنا عن introduction, physiology, pathophysiology, classification and diagnosis and how to evaluate a diabetic patient، واتكلمنا على تايب 1 diabetes. بارت 3 اللي احنا هنبتديه النهارده هنتكلم اساسا على تايب 2 diabetes. تايب 2 diabetes mellitus. To start with, we need to understand that what is the major difference between type 1 and type 2. We already mentioned that type 1 diabetes is characterized by immune-mediated destruction of the pancreatic beta cells. Type 2 diabetes, it is associated with initial insulin resistance followed by defect in the insulin secretion. And the nature of type 2 diabetes is a progressive disease. What do I mean by this? The process starts with insulin resistance. Insulin resistance is primarily caused by obesity and overweight. Remember the metabolic syndrome. People who are obese, who are having, in particular, abdominal obesity, they have what is called insulin resistance, decreased insulin action on the level of the cells due to increase its fat content, which means that the patient has to increase the amount of insulin to maintain a constant blood glucose level. So insulin resistance, it leads to hyperinsulinemia. Initially, the pancreas will be able to compensate for the insulin resistance by enhancing its insulin production. By time the pancreatic beta cells will be burned out, exhausted. So we shall enter into the stage of pancreatic beta cell decompensation, and then the process will start, and the patient will start passing into the stage of impaired glucose tolerance until he reaches a total stage or a stage of total pancreatic beta cell failure, and the patient will become a full-blown picture of type 2 diabetes mellitus. So we can view that hyperglycemia in type 2 diabetes is actually a multifactorial, partly because the impaired insulin secretion, and impaired insulin secretion results in increased glucose output by the liver through the process of gluconeogenesis. At the same time, defective insulin secretion will result in decrease in the glucose uptake and its utilization. This is a very nice diagram which shows that the complexity and the multiplicity of factors contributing to hyperglycemia in type 2 diabetes, starting from the central mechanism, which is actually until now it's not entirely understood. Decreased satiety might be related to hormonal alteration, increased glucose production by the liver through the process of gluconeogenesis, decreased insulin secretion, and increased glucagon production by the pancreas. And as we shall know later, there is a very important contributing factor for hyperglycemia, which is decrease in the incretin or decrease in glucagon-like peptide 1 secretion from the intestine, decreased glucose utilization, and a very important thing, increased release of free fatty acids, because defective insulin secretion results in enhanced lipolysis, and increase the level of the free fatty acids actually contributes to the process of what is called glucose toxicity. So all these are contributing factors for hyperglycemia. Now, we spoke about that the type 2 diabetes is a progressive disease. Have a look here on the initial phase. The initial phase in which there is the start of the stages of diabetes by what is called the stage of glucose, impaired glucose tolerance. There is actually increased in the insulin resistance, but here, have a look here on the blue line. The pancreas will be able to compensate by increasing insulin production. But over time, there will be decline of the insulin production because of the beta cell pancreatic decompensation until it enters into the stage of complete failure. Note here, usually the patient is diagnosed on this stage, which is not diabetes. Here, very, very common to find that the patient, after they present, we will find evidence of complications. And it is not a surprise that patients who present at this stage, we can find actually evidence of both microvascular and macrovascular complications, and we shall understand the difference between the two. The bottom line is, it is very common that at the presentation of type 2 diabetes, there is an evidence of complications of the target organs. And here, this is a nice diagram because actually the increased liberation of free fatty acids, it increases the gluconeogenesis by the liver, and it suppresses the insulin secretion. So increased lipolysis in a way actually contributes to the hyperglycemia in diabetes mellitus. And again, this is a very nice diagram. Look here at the interval as the disease of type 2 diabetes progresses with time. There is a decline in the total mass of the pancreatic beta cells. And this decline, it will reach a stage in which there will be complete loss of the effectivity of the efficacy of the oral hypoglycemics. And once the patient starts or actually enters into the stage of complete pancreatic beta cell failure, there is no alternative except for initiating insulin therapy. Here, this table actually, it shows the natural history of diabetes. The initial phase in which the patient actually enters into the pre-diabetes stage, which is impaired glucose tolerance. Through modifying the lifestyle, we can revert the abnormality back to normal. We call this stage the primary prevention, which is preventing the development of diabetes. But here, after the diagnosis, we control diabetes to prevent the complications. We call this the secondary prevention. The tertiary prevention is the appearance or the occurrence of complications, but we take measures so that these complications will not repeat themselves, which is called tertiary prevention. What is the clinical presentation of type 2 diabetes? Now, the clinical presentation occurs when the blood glucose level exceeds the renal threshold, which is 180, and this results in polyuria. So hyperglycemia is associated with polyuria, and this is usually the stage at which the patient starts to present. But before the stage of polyuria, in other words, before the blood glucose level reaches the renal threshold, usually the patient is asymptomatic and he can be diagnosed accidentally by performing a routine blood glucose measurement test. And we need to also realize that, as mentioned previously, the stage, or actually the type 2 diabetes, it is not a static process, but actually over time there will be a decline in the pancreatic beta cells. So actually the stages of the disease are progressive. In other words, it is not a surprise that many patients with type 2 diabetes, after an initial control with diet and oral hypoglycemics, we start to realize that the efficacy of the diets and the oral actually are not effective, and the blood glucose gets out of control. And in this case, it is caused by the marked decline in the pancreatic beta cell mass, and the end result will be complete switch of the patient from the oral hypoglycemics into parenteral insulin therapy. And as mentioned, it is not a surprise that many patients at the onset of presentations, we can actually have an evidence of complications, because actually before the presentation, there is a long stage of hyperglycemia, which was undiagnosed. One of the uncommon presentations of type 2 diabetes is diabetic ketoacidosis. The reason is, although patients with type 2 diabetes, they have insulin deficiency, but they have a very small amount of endogenous insulin, and it is this very little amount of insulin present which will prevent the conversion of free fatty acids into ketone bodies. That's why diabetic ketoacidosis is not a common presentation of type 2 diabetes, because of the remaining small amount of insulin, which will prevent ketogenesis, which is the formation of ketone bodies from free fatty acids. However, some patients, they might present with diabetic ketoacidosis, and sometimes we call this peculiar entity ketosis prone or flatbush diabetes, and this is a name of a district in the United States of America. And it was found that those patients with ketosis prone type 2 diabetes, after they recover from diabetic ketoacidosis, some of them actually, they restore normal blood glucose level for many years, but eventually they will develop a frank picture of type 2 diabetes. Now, regarding the treatment of type 2 diabetes, the treatment of type 2 diabetes can be viewed as composed of three parts. Diet and lifestyle, this is the major part, because most patients are overweight and obese, so we have to regulate the diets, and lifestyle in the form of exercise and weight loss. There is a line of treatment which is called bariatric surgery. I will discuss it briefly before we proceed into the drug or the pharmacologic therapy. Bariatric surgery is the type of the surgery which is used for weight loss. And now it is a standard operating procedures that bariatric surgery has a very, very important role in the management of type 2 diabetes. especially if the patient is having a body mass index beyond 40. So if you have a diabetic patient type 2 and the body mass index is more than 40, this is a frank indication for bariatric surgery, which is the surgery used for weight loss. And you don't need to know the details of the bariatric surgical procedures, but actually the most famous types is the gastric banding and the sleeve gastrectomy. You don't need to know the details, just know what is meant by bariatric surgery, and the most common types or the most common bariatric surgical types is the gastric banding and the sleeve gastrectomy. Now, when we come to the drug therapy or pharmacologic therapy for type 2 diabetes, there are certain rules or certain principles that need to be addressed. Number one, the earliest initiation of drug therapy is preferred, and usually we prefer to start with one single drug, and usually the initial choice for the oral therapy is the metformin on some of the secretagogues, insulin secretagogues, as we shall discuss later. And we need to address here that some of these medications, in order to exert their maximum effect, it will take some time. For example, initiating the medication of like metformin and thiazolidine-diones, the peak effect, it might take several weeks to reach its maximum effect. The importance of knowing this information is that some physicians, after they initiate therapy with metformin or thiazolidine-diones, the blood glucose level will not drop over a night or over 2 or 3 days. Sometimes this process might take weeks. The reason is those medications, they will take some time to reach a therapeutic level which will enable them from lowering the blood glucose level. There is another important thing. Sometimes when you see a patient and you find that the blood glucose level is very high, to be more specific, more than 240, or the FD glycosylated hemoglobin is more than 9, in this case, monotherapy will be a waste of time, and it is wise in such a condition in which you are confronted with a patient with an initial high glucose level to use combination therapy in which you choose 2 different oral hypoglycemic drugs from 2 different classes, or preferably that you do a combination between long-acting insulin and an oral hypoglycemic drug, as we shall discuss later on. Now, what are the available medications for type 2 diabetes? We can divide them into oral and parenteral. The oral are biguanides, alpha-glucosidase inhibitors, dipeptidyl peptidase 4 inhibitors, insulin secretagogues of the sulfonyl urea class, and insulin secretagogues of the non-sulfonyl urea class, thiazolidine-diones, and the last group is the sodium glucose cotransporter inhibitors. These are the oral medications. The parenteral medications are insulin, glucagon-like peptide 1 agonist, and amylin agonist. Now we need to address some issues related to the oral medications of diabetes mellitus type 2. Number one, we need to understand the role of incretins. What are the incretins? To understand the principle or the rationale of incretins, it is a very well-known fact that the amount of carbohydrate administration by mouth, it generates a more pancreatic insulin secretion. In other words, if you give the very same person a big amount of glucose orally and the same amount intravenously, he will produce a bigger amount of insulin when he is receiving the oral route. And it was found that the oral administration, it elaborates, it releases certain hormones from the gut which help to regulate the blood glucose levels. These are called incretins. And those incretins, the prototype of them is a very famous incretin called glucagon-like peptide. Now, what are the actions of glucagon-like peptide which is released from the gut after carbohydrate load? Number one, it increases the insulin secretion, it decreases glucagon production, it decreases gluconeogenesis by the liver, and it suppresses appetite. So actually the incretins or glucagon-like peptide, it has a fantastic effects to control the blood sugar. And from here came the idea of utilizing the glucagon-like peptide as a line of management of diabetes. And this line of management, it includes the therapeutic potential of glucagon-like peptide in managing diabetes. Because number one, it will have a very positive effect on the pancreatic beta cell function, increasing the insulin production. It will prolong the life of the pancreatic beta cell, and it will decrease the decline of the pancreatic beta cell mass. it will also decrease the glucagon production, and it will suppress the appetite, and it will enhance the satiety. So it has a wonderful effects to be used as a therapeutic agents. Accordingly, there are two current strategies in order to utilize the effects of glucagon-like peptide in managing diabetes. The first approach is to synthesize compounds which will actually inhibit the enzyme which will degrade the glucagon-like peptide. So we have a group of medications which are called the inhibitors of degrading enzyme, or dipeptidyl peptidase inhibitors. This will maintain the glucagon-like peptide, or I can use a synthetic agent acting on the receptors of glucagon-like peptide. We call them glucagon-like peptide receptor agonists. So the current strategies which are dependent on the rationale of incretins are glucagon-like peptide receptor agonists, or inhibitors, or the dipeptidyl peptidase inhibitors. And again, have a look on this diagram, which will show the beneficial effects of both, whether the glucagon-like peptide agonist or dipeptidyl peptidase inhibitors. It enhances insulin production, it decreases glucagon production, it decreases the gastric emptying, it suppresses the activity, and all of them are quite beneficial effects to control the blood glucose. So we have here two major categories of the incretin rash, or the incretin effect medications. One of them is called the glucagon-like peptide receptor agonist and dipeptidyl peptidase inhibitors. The major difference is dipeptidyl peptidase inhibitors. It is available in the form of oral tablets, but the glucagon-like peptide receptor agonist is available in the form of injections. Now, one of the interesting new class of medications which are used for treating type 2 diabetes, it's called sodium glucose cotransporter inhibitor. This group of medications, it acts by inhibiting the absorption of glucose by the kidney. And this mechanism is entirely independent from insulin, which means once the patient receives those drugs, he will lose a big amount of glucose in the urine. Subsequently, the blood glucose level will drop and the control of blood sugar will be achieved. So sodium glucose cotransporter blocker inhibitors, actually, it acts by increasing the renal loss, or actually it inhibits the absorption of glucose, increasing the loss of glucose in the urine, and subsequently the blood glucose level will drop. Subsequently, there will be an enhanced insulin sensitivity by the peripheral tissues, and there will be improved insulin secretion, because hyperglycemia sometimes it leads to what is called glucose toxicity, in which the elevation of blood glucose for a long time, it has a toxic effect on the pancreas. So by lowering the blood glucose, there will be a chance of the pancreatic beta cells to recover and to regain its secretory ability to produce more insulin. What are the side effects? The most important side effect of the sodium glucose cotransporter, since there will be an increased amount of excreted glucose in the urine, this will enhance the growth of bacteria, precipitating infections. And one of the most serious, dangerous types of infections is called Fournier gangrene, which is gangrene of the perianal area, and this is a fatal condition. However, they are now popular drugs, and they can be used in a wide indications for managing and treating diabetes mellitus. Now, to resume, or actually to make a summary for the anti-diabetic drugs, now I have provided you here with a table. We have the biguanides, the sulfonylureas, the secretagogues or the non-sulfonylureas, which are called meglitinides. We have the thiazolidinediones, alpha-glucosidase inhibitors, and we have the dipeptidyl peptidase inhibitors. This is a very important group. And we have the glucagon-like peptide agonist. And finally, we have the sodium glucose cotransporters. Remember that we have different types of insulin, because sometimes we need to administer insulin even for cases of type 2 diabetes. We have the rapidly acting insulin, the short acting. The difference between the rapidly acting and the short acting is that the rapidly acting are synthetic, and they are called insulin analogs, and they include the insulin lispro and insulin aspart. And remember, the long-acting or the basal insulins include the Levemir and the Lantus, and it also includes the insulin degludec. And this is an image for the insulin, classic insulin injection and the insulin pen. And actually, most treatment right now to treat diabetes mellitus, we rarely use the classic injections, and we always use the insulin pens. Now, this is a nice diagram, but I will show a diagram better. Remember this diagram. This diagram, it shows the pathogenesis of hyperglycemia in type 2 diabetes. We have decreased satiety, we have a problem in the liver, problem in the pancreas. Subsequently, the other diagram, it will show that the various types of drugs which are used, each one of them, it acts on a particular area. For example, control of appetite, this is the rationale of the incretin derivatives, and decreasing glucose or the increased insulin glucose loss by the kidney. This is the site of action of sodium glucose cotransporter. Enhancing the glucose utilization. This is the mechanism of thiazolidinediones and metformin. Minimizing the lipotoxicity and minimizing the release of free fatty acid. This is the mechanism of action of thiazolidinediones, and decreasing the glucose output production by the liver through the process of gluconeogenesis. This is the function of metformin and thiazolidinediones. And finally, enhancing insulin secretion by the secretagogues. It is the action of sulfonylurea, migletinides, and incretins. Now, finally, we will see what is the algorithm for treating type 2 diabetes. We always like to start with lifestyle, weight loss, diet, and metformin. Usually, or actually, it's almost always that we start with metformin. If we don't have a good result, you can combine metformin with another medications. And if you are unsuccessful, so it will be a combination of metformin with insulin. This diagram here, it is a better or more detailed diagram for managing type 2 diabetes. You start by lifestyle, and then if inadequate, you start by using metformin. If it is inadequate, in this case, you will use metformin together combined with sulfonylureas, or you combine metformin with dipeptidyl peptidase inhibitors. If you are unable to control it, so you will combine metformin with some of the basal insulins. And if this is not enough, then you will switch entirely to insulin, whether the pre-mixed or split dose regimen, or more rarely the basal bolus combination. This concludes part 3, and next time we will be speaking about the acute complication of type 2 diabetes, which is hyperosmolar non-ketotic syndrome. We will speak about hypoglycemia, and we will speak about the chronic complications of diabetes. Thank you.